Welcome everyone to this webinar, COVID Known Unknowns, in which we'll be focusing on schools. I'm Fiona Godlee, Editor-in-Chief of the BMJ, and on behalf of the BMJ and our partners in these webinars, the University of Bristol, University of Newcastle, George Davey Smith and Allyson Pollock, are my colleagues in helping to prepare these webinars, and our teams at the BMJ and in our partner organisations. This is a series of webinars that stems from an editorial that we published in the BMJ on the 19th of October by George Davey Smith and Marcus Munro, called COVID-19 Known Unknowns. The subtitle of which was, "The more certain someone is about COVID-19, the less you should trust them." The sentiment in the editorial was a concern about the polarization of debates and hardening of positions on key issues, making it hard to make really good progress on our understanding about how to respond to this extraordinary pandemic. The editorial called on us all to move away from certainty, rigid certainty, and to respect uncertainty. It said that acknowledging uncertainty a little more might improve not only the atmosphere of the debate and the science, but also public trust. And that is the spirit of this series of webinars. On November the 20th last year, we did a full day, an overview of the issues around COVID-19, which is available on the BMJ's YouTube channel. And that's where this session that you've joined will also be posted. Now, we are planning a series of these 2-hour webinars to follow up. So we're aiming for one every 2 weeks. That's going to be quite ambitious. And our thanks to Zoom, who have provided us with a free Zoom license for these webinars. This webinar, as you know, is on schools. The next one will be on testing in 2 weeks' time. And after that, we'll be looking at vaccines, and we're open to other suggestions from you about what we should look at. We're really thrilled that 2,800 and more of you have registered to join from all around the world: researchers, public health physicians, teachers, parents, children, students, and some journalists too. So we've got a fantastic group of people listening, some great speakers, very tight on the timing. We'll aim to look at all aspects of this very complicated issue. Your questions are welcome. I should say that we're not going to be talking about testing. As I say, that's next time's topic. We won't be looking specifically about how to return schools safely to being open, and nor will we be able to look at any individual concerns about your child or your school. But we will be looking about community transmission, risks to students and teachers, impacts of school closures, and international perspectives. And I hope that despite the tightness of time, we will be able to inform and progress this very important and topical debate. We're lucky to have as our master of ceremonies, Phil Hammond, who I'm going to hand over now to tell us how it's all going to work. Phil.
Thanks very much, Fiona, and welcome to you all. It's lovely to be with you again. Many of you will have joined us last time. A quick note about questions. We welcome your questions. There's a Q&A button you'll see at the bottom of your screen. Please tell us who you are. We won't be answering anonymous questions, and if you go off message, we won't be answering them either, but we'll try and get through as many of those as we can. I love the idea of the known unknowns theme. Adam Kuchelski, in his excellent book, Rules of Contagion, says, when you've seen one pandemic, you've seen one pandemic. There's lots we still don't understand, particularly about schools, which is why this is so pressing. In the UK or in England, we may not be going back till March the 8th. So let's lay out the evidence before then. If you're not able to see all of this, it will be up again on the BMJ YouTube channel. So any of your colleagues who aren't able to look in today can check out that, and then all the seminars will be up. But let's get straight on to our first one. It's on community prevalence, transmission and dissemination. It's chaired by George Davey Smith from Bristol University. So I'll hand over to George. George.
Great, thanks very much, Phil. So I'll move straight on to introduce the first of two speakers in this session on transmission, Alasdair Munro from Southampton, who's going to start the session.
Thanks, George. Hi, my name's Alasdair Munro. I'm a senior clinical research fellow in paediatric infectious diseases. I've been leading the review of evidence of COVID-19 in children for the Royal College of Paediatrics and sitting on the NIHR Transmission of COVID in Schools Working Group. And today I'll be talking about SARS-CoV-2 transmission in children and schools and their role in wider community infections. So topics we'll cover today include basic tenets of transmission, looking close up at children's susceptibility to COVID and their infectiousness, the impact of the environment of schools and transmission therein, and then wider community epidemiology of infections in children, and the role of schools in those trends. So just to make sure that we all understand the same things when I use these terms, transmission and the measurement of transmission specifically refers to looking at infection being passed from one person to another. And this is different from prevalence, which is the total number of people infected at a given point in time. So that's an important difference. When we talk about studies and an index case, that refers to the first person detected to be infected, or often the first person symptomatic within a cluster or network. The secondary attack rate is the proportion of contacts who become infected within a network, not the absolute number, but the proportion. And when we refer to young children, we're normally talking about primary school age children and below. And that's an important differentiator because, as you'll see, there are some probably biological and epidemiological differences between young children and adolescents. So when we think about transmission, there's four main tenets that we need to think about. One is the pathogen, which in this instance is SARS-CoV-2. The next is the host. And in the case of children, we need to think about their susceptibility to infection, their disease burden, and their infectiousness to others. Exposure is really critical to transmission. And in exposure, we can think about the environment, with poorly ventilated and indoors being higher risk than outdoors or well ventilated, the duration of exposure, proximity, the nature of contacts, and then any other mitigating factors therein. And finally, the hosts who are receiving the infection, their susceptibility. And in our case, that could include other children, family members, or teachers. So looking at the susceptibility of children, the best way to try and ascertain this is via household contact tracing studies. And the reason for that is that the exposure is relatively well controlled in that environment. And we assume that everyone within the household gets similar types of exposure. The majority of these studies have been quite well conducted and test all contacts regardless of their symptom status. And that's important because it eliminates a potential bias for children who may have a lower symptom burden. The international data in these studies has been relatively consistent. There is some variability, but there's a large number of studies now, which means that we can pool them together and do a meta-analysis, which is when you combine the results of many studies together to get a more consistent overview of the results. Here are some of the results of some of those bigger and more well-done meta-analyses. And as you can see on the left there, the relative risk or odds of a child having been infected in a household is roughly half of that of an adult. And the graph here is from Russell Viner's meta-analysis paper. And that red diamond at the bottom being to the left of the vertical line just indicates children being less susceptible, in this case, by less than half. So we can say the secondary attack rate in children has been about half of that in adults in household contact tracing studies. Infectiousness has been much more difficult to ascertain from these types of studies. We do have several from countries around the world, but children have been grossly underrepresented as index cases. And the results of these studies have been quite mixed, some showing children to be less infectious, some equal to adults, and some more. But there are some quite significant biases in these studies. Co-primary or shared exposure, which I will discuss more in a moment, and then index ascertainment bias. And by that, we mean to be an index case, to have your infectiousness measured, you must almost always have been symptomatic. This is a problem for children where we think up to half of children may not be symptomatic. And we have good reason to believe that asymptomatic individuals can be half or less as infectious as symptomatic. So if we're only measuring symptomatic children in these studies, we will probably overestimate their infectiousness. To explain shared exposure bias, this happens when, for example, you find a child, case A, who is infected, you test their contact B, who is also infected, and you assume that A has infected B. Whereas what has actually happened was A and B were together at the time they were exposed to C, the initial infectious person, and then we don't know if C infected A and B, if C infected A, who infected B, or C infected B, who infected A. So this is a really difficult bias to overcome. And for children, we know it's significant because, for example, in South Korean contact tracing data, 40 out of 41 infected contacts had shared exposure to the initial infectious person. So it makes it very difficult to really know how infectious children are in that context. An example of a large contact tracing study that looked at this was from southern India, published in Science. You can see from the circled area here, the heat map shows a high density of children infecting children of the same age. So this is a high proportion of contacts becoming infected. But in the same study, we can see the number of index cases of children was extremely small compared to that of adults, which, as we've discussed, can introduce a significant bias. Some more recent data from NHS Test and Trace looked at infectiousness according to age and CT value. And we can see here that young children have the lowest rates of contacts who test positive. Limitation here is that this was symptom-based testing. For schools in particular, there are actually quite a large number of studies now looking at contact tracing within schools, mainly during areas of times of low prevalence, but there have been very limited evidence of transmission within schools. There has been some large outbreaks, mainly in secondary schools and mainly during periods of high prevalence, for example, in Israel and France. Almost very reliably, frequency of transmission and the size of outbreaks increased with age of the children, and there has generally been a higher attack rate found among teachers than pupils. The ECDC has done an excellent technical review of all of these papers, as well as reports from some of the surveillance units in different countries. And their summary was that child-to-child transmission in schools appears relatively uncommon. I know the US CDC published a report saying something very similar yesterday. PHE, Public Health England, have collected some data on this, thanks to Shamez Ladani for sharing this with me before it's been published. They surveyed 190 geographically representative schools of their outbreaks leading up to October 18th. In that time, in total, there are 450 outbreaks in primary schools and 519 secondary. And you can see that that's 15% of secondary schools as opposed to only 3% of primary schools. There was a much higher attack rate amongst pupils in secondary than primary schools. And in primary schools, staff made up the majority of cases as well as the majority of index cases. So quite a big difference there. There have been concerns that because of a number of these studies have been conducted on the basis of symptomatic-driven testing, they were missing large burden of asymptomatic disease within schools. Fortunately, the Office for National Statistics has performed a school infection survey where they tested people in school on the day who were presumably asymptomatic. They found very similar rates of infection in teachers and pupils and lower rates in primary schools than secondary schools. And we must remember that our upper limit of asymptomatic infection in children is only thought to be 50%. So very large outbreaks going missed are unlikely. Here I've circled comparison of secondary schools in high prevalence areas and secondary and primary in low prevalence. And you can see primary schools, there were no cases detected in low prevalence areas in school on the day. Now, to discuss community epidemiology trends, I'll be focusing on England here. And again, thanks to Shamez for sharing some of his graphs with me. We can see that at the beginning of August, cases were already beginning to rise predominantly in young adults, and that before schools even opened, there was an uptick following behind this in teenagers in red and primary school age children in the dark pink. That continued throughout the autumn term. There was a slight dip following the half term, more in secondary age children than primary, indicating they may be more school sensitive for their prevalence than primary age children. And then following the national lockdown, quite a quick decline in cases in adults, which was then also followed by declining cases in secondary and primary school age children a few weeks behind, despite schools remaining open. This is consistent with data in other countries who have locked down with schools open. But unfortunately, the story didn't end there. This is educational age cohorts only with green secondary and red primary. And you can see following this dip at the end of the lockdown, once lockdown was released and the new variant B117 emerged, there was a rapid increase in cases amongst all cohorts, which occurred simultaneously. And this is different to previous times where we've seen cases rise in young adults before children. This is just a graph to show cumulative data from Europe, where the same sort of trends have been observed, with cases rising, first of all, in the young adult population, and then several weeks behind that, it tends to rise in younger children and primary school age children. Now, we know that for case detection that is symptom-driven, we do significantly underestimate the true prevalence in children. Because of their lower symptom burden, they just get tested less. And we're very fortunate in the UK to have two infection surveys that sample people at the population regardless of their symptom status. And they have found significantly higher prevalence in children of all ages when this has been tested. But the trends remain the same. So we see the same pattern of cases rising first in the young adults, followed not too far behind by secondary school age children, but primary school age children really in the middle of the pack the whole way through until we had a period where everything else was closed except for school during the national lockdown in November. And again, there was the drop following the lockdown and then a sudden rapid increase across all age groups once lockdown was lifted and the new variant emerged. We can see that school closures towards the end of the year had quite a significant effect in secondary age children, much less so in primary, again backing up that secondary age children's prevalence is probably more school sensitive than primary age. An important point that I think has often been overlooked is that we expect to find significantly higher rates of infection in children and transmission based on the number of contacts they have relative to adults. You can see here the dark blue bars on the left for children are extremely high, and that indicates the amount of contacts they're having with people of the same age. The fact that children have the same or often lower prevalence than adults is another indicator that they're potentially less infectious or have reduced susceptibility. Evidence gaps that remain really are prospective studies of asymptomatic transmission within schools, so routine testing through non-invasive means. The Tox Committee have been working on a project to this, as yet unfunded, but as well as bringing together the chief investigators of some other excellent studies of transmission in children. So in summary, younger children appear less susceptible to acquiring infection than adults, and probably somewhat so for teenagers, but more similar to adults. The relative infectiousness of children is unclear, but we know they can be infectious when asymptomatic. In-school transmission between children is relatively uncommon in periods of low to moderate prevalence. However, it is higher in secondary schools than primary schools. Young children's epidemiology trends tend to just follow behind adults. They are somewhat school dependent, but that's much more true for older children than it is for primary school age children. These are the people I'd like to thank. That's all I have to share for today, and I'll hand over to Muge now, who I believe is going to speak somewhat to modelling and the new variant.
Thank you so much, Alasdair. This was a great overview. So I will be actually going over some international data and looking at schools and children from a more population level. I'm a clinical academic at University of St Andrews, and I'm also infectious diseases clinician in Edinburgh. These are my disclosures. I have no conflicts of interest, still being paid by my university. So I think when we look at and discuss about schools, we need to consider 4 themes. So as Alasdair already discussed, we need to look at what's happening when schools are open. And when schools are open, are these infections spilling over to the community? The other aspect we need to look at what's happening to the household. Are these children bringing infection into the household? And 4th theme is the overall impact of schools when we look at all non-pharmaceutical interventions we put in place. So looking at in school transmission, we know that outbreaks in schools can happen because we know that there are outbreaks, but these are highly stochastic, meaning that sometimes it's really big and it can explode, while others it fizzle immediately. And generally, when we look at international data, school-based transmission occurs in a limited capacity. Most of them are usually small. So for example, this is data from Vermont, where they had very low community transmission. But what they found is that 14% of cases present on school ground or at school events were likely to result in transmission in school. So majority of these cases don't actually lead to in-school transmission. And this is actually really related to the community prevalence. So if the community prevalence is low, we see lower outbreaks. And if it's higher, we see higher size outbreaks. In this one, you can see primary and secondary schools. This arrows shows increased community prevalence, and you can see more cases with more higher community prevalence. But you can see the difference between primary schools and secondary schools, and this is potentially related to what Alasdair already mentioned in regards to susceptibility difference between primary and secondary school kids. But also we need to look at the contact patterns of different age groups. For example, the left one shows what's happening in primary schools. So they're basically clustered tightly in their classrooms, whereas secondary school kids mix much more broadly, not only with other classrooms, but also they have a lot of out-of-school contacts. Looking at spillover to communities, so yes, I mean, outbreaks happen, transmission can happen in schools when they're open, but does it spill over to the community? So when we look at, for example, this was discussed quite rigorously in Israel, they looked at how school reopening had an impact on general population prevalence. And C is the point where they opened schools. You can see an uptick here. This was a single day surge in positivity rates in one high school. And afterwards, they haven't seen much infection in schools, and it actually hasn't reflected to the general population prevalence. And what they found is that they haven't seen any increase in terms of hospitalization or death following school opening. But you may say that this was around the time when they had very low prevalence. So what happens when you have really high prevalence in the community? So in England, what we saw is that when schools are fully open and the rest of the society is under restrictions, as it happened around November, December time, we saw more cases in kids compared to adults. But this is in a way unsurprising because transmission happens when you have more contacts. After school holidays, what happened? Some suggested looking at the ONS modeling data, which is on your left. Basically, it looks like showing decrease in cases in kids and increase in cases in adults. But this is a model. And when we look at the raw data on the right, that actually shows all the cases are going up, even after school holidays. So I think all the international colleagues, interpreting this data needs to be careful and look at the raw data. So what happens to households, whether infections in kids, does it spill over to the households? So I guess we need to look at from this perspective, who brings the infection into the household highly depends on who has the most non-household contacts. So if only children has an outside contact, if a child goes to the school, that will be the only case bringing the infection to the household. But if all household members have outside contact, so if they work outside of the household, there will be a difference in who brings the infection to the household. So what we're seeing in international data is, as Alasdair also suggested, based on contact tracing data, working age adults are more likely to bring infection to the household. There's one modeling study from England that showed kids were more likely to bring infection to the household. But I think it's important to emphasize that this is not a contact tracing study. This was based on ONS random sampling, not looking into same households. And there were several assumptions made, basically considering that children less than 18 had 4 times more external exposure, and they considered they're less susceptible. And this basically modeling doesn't consider differences in different age groups, so it needs to be interpreted really cautiously. And because this is not a contact tracing data, we don't have genomic data, we don't know who actually infected whom, so it shouldn't be viewed as causal. But are we missing the index cases in kids because they're asymptomatic? I think Alasdair already mentioned that. What we're learning more is that secondary attack rates is actually higher when the index case is symptomatic, even in the same household. So asymptomatic cases transmit to fewer contacts. So last point is the overall impact of schools. So the reason I think there's a lot of discussion between different people is because we're seeing differences. When we look at different studies, there are a lot of uncertainties. These studies were looking at the effect of school closures, whether it reduces the community transmission. As you can see, these studies show from no effect to really high effect. And it really depends on whether there's a bias in the study and how well it was performed. So there are 2 studies on the top which has low bias and they showed no effect. But as I said, like effect sizes range from no association to important reduction. I think this is the mostly cited and discussed study, which was published in Nature. Basically, they looked at different effectiveness of non-pharmaceutical interventions, and this showed the closure of educational institutions were highly effective. But I think it needs to be considered that educational institutions are not undifferentiated mass. So nursing, so primary schools, secondary schools, universities have a different influence into community prevalence. And assessing the effectiveness of different MPIs is challenging because most of the countries actually put all these measures at the same time. So the last point is the variant. So I think there's been a lot of discussion whether the new variant is actually transmitting more in children. So at the moment, according to the recent data, there's no evidence to suggest it favors children more than adults. It seems to be transmissible across all age groups equally. And you can see the contact tracing study here from Public Health England, which basically shows that the new variant has higher secondary attack rates in all age groups, but similarly to the older variants, age-related susceptibility seems to be similar. As you can see, the children still have lower secondary attack rates. So in conclusion, when schools are open, there's evidence to suggest in-school transmission, but these are stochastic events, majority are small, but some can be large. Mitigation measures reduce this risk further. What we know is that size of school outbreaks depend on community prevalence, and secondary schools have much higher size outbreaks than primary, but there are still many unknowns, especially the impact of schools on community prevalence, hospitalizations and deaths. We still don't have good studies. Could school closures be based on local and school-based data? So there are still many things to discuss, but I think ultimately how and when to open close schools is not only a scientific decision, because I think schools provide more than education. And this is my last slide. I think we need to consider that public health is also so much broader than infection control. Thank you.
Brilliant. Thanks for two really good talks, compressing a huge amount of data. These are questions that have come in, and we've grouped them into composite questions. There's several questions asked about the role of masks and ventilation in schools when pupils are returning.
I guess it's hard to answer that with a really data-driven approach, because there are no high-quality studies or really very few studies at all that really examine the effects of any specific interventions. So we're working really on general principles that can be applied from studies in other settings, where we know that in general, mask use when worn by at least the majority of people in a setting will reduce the likelihood of transmission, that increasing ventilation will reduce the probabilities. But obviously it's hard to speak to the specific effect in a given setting when we unfortunately don't have the data, and the studies haven't been done to tell us exactly what effect applying those interventions and to what level would have. I don't know, Muge, if you have any other thoughts.
Yeah, I mean, I agree with you. I think looking at the studies, especially isolating away the infected, especially symptomatic children, were seen to be more effective. And I think class sizes could have an influence on the outbreak size. But generally, I think we've basically observed smaller outbreaks in schools, and especially if some measures are put in place. Great.
And another question is, how about using extra premises, i.e., extending the area available for teaching? Using areas external to the school, so that the kids can be kept at greater distance.
Yeah, I mean, I suppose really anything that addresses those, because we're really talking about the exposure. So we're trying to reduce exposure. So increasing distance, decreasing the proximity of contact, of the duration of contact, all of these things would decrease transmission. And I suppose the issue is it becomes a logistical one. I know, so Muge showed an excellent graph looking at the contact networks, for example, of young children in primary schools versus secondary schools. And a lot of that is logistical to do with the curriculum and the nature of education. So I think there are a lot of things that could be done, but the barriers are predominantly logistical ones, I think.
And finally, for this session, one obvious difference between primary schools and secondary schools, as well as the age of the pupils, is that primary schools are generally considerably smaller than secondary schools, and smaller populations get less sustained outbreaks. Is that playing a role in this age pattern?
I imagine it would do, but I guess given that in general, where outbreaks have been detected, they tend to be a median of about 5 cases. I wouldn't have thought that for the majority of the time that would play a huge influence. I imagine, again, Muge mentioned how stochastic the events are. So I imagine given the much larger population within secondary schools, the possibility of having very large outbreaks is bigger because there are simply more people who could potentially become infected if there were a large, super spreading event.
Yeah, and I think, important to emphasize that, it depends on various factors. So transmission is not only one-dimensional. And we also need to look at, for example, household structure, deprivation. For example, in England, we saw much more outbreaks in secondary school in most deprived areas. So they potentially are more likely to be maybe crowded, but also those kids might be living in much more crowded and multi-generational households who are also at higher risk of infection outside of the household. So there are multiple factors that we need to take into account.
Great, thanks. Well, thank you. There's more time for questions at the end, hopefully. I'm going to hand back to MC Phil, just to say, if you do tweet, the hashtag for this event and for all of these events is hashtag COVID unknowns, all as one word, and information about the future webinars will be put out with that hashtag too. Thanks very much. I'll hand back to Phil. Phil's muted.
Phil, you're on mute.
On mute.
Yeah, you would have thought he'd have learnt by now.
Look at
He's
that.
a professional. I was told this guy was a professional. Come on.
Stop it. That's just very mean. I've had a very stressful time. Thank you for that. I like the idea of thinking outside the school, because there are lots of churches, theatres, halls that are probably have far better ventilation than many hermetically sealed classrooms. So that's maybe a thought. Also worth pointing out that most schools aren't closed at the moment. My son's primary school has 100 kids in it, so pretty busy. And we're interested to see what research into that's going on at the moment. But we're now moving on to clinical risks, and I'm going to hand over to your chair, Allyson Pollock from Newcastle University. Hello, Allyson.
Hello, Phil. Thank you. We've got a great session coming up, and I'm going to go straight into it. We have Elizabeth Whittaker talking about severe disease, long COVID, and risks to children next. And then that will be followed by Rachel Woods talking about risks to teachers. Thanks, Elizabeth. Away you go.
Oh, thank you.
I'm timing you now.
You can see my slides and hear me. Lovely.
You're a little bit faint.
Bit faint. Okay, I'll shout. Nobody will be pleased to hear that. Thank you very much for inviting me to speak. I'm a paediatric infectious diseases consultant at St Mary's Hospital in Paddington and on the expert advisory group for the Royal College of Paediatrics and Child Health. And I guess that the aim of my talk really is to discuss whether or not schools are safe for children. And what I hope to show you is that schools are safe to children, but we do need to do quite a lot of work. So this graph here just shows you the number of people who've been hospitalized and sadly who've died in purple and in proportion to their age. And the red box is to show you that for young people under the age of 35, although sadly no longer in that box, the risk of both hospitalization and death is very low. And this data has been available to us since the very earliest reports from Wuhan, and I think very reassuring to us both as parents and as paediatricians, and I'm sure to teachers alike. And this is a figure from a review article earlier on this year, showing that majority of children experience asymptomatic mild moderate disease. And in fact, this 3% of children having severe or critical disease is probably less than 1% at this stage, now that our testing capacity has increased, as we know that 30 to 50% of children have asymptomatic disease. And this figure from Don't Forget the Bubbles and Tessa Davis just actually shows every tragic death that's happened to a child due to COVID-19 in the last year, which is 28 in total, across the age ranges, with a bigger group here in the older teens, unfortunately in April, and really quite low numbers, in fact comparable or less than those numbers of children who die from other conditions like meningococcal disease or chickenpox, or indeed flu in a bad flu year. So COVID-19 for children does not result in severe disease and death on the majority of cases. Who do we see in hospital? So mostly it's children under a year of age or older teens. The children under a year, we know that there's slightly more severe disease in the little babies under 3 months, although they actually turn around and get better quite quickly, which is lovely. And we tend to admit children under a year more cautiously because we know that they can be more vulnerable to severe disease. And then again, once teenagers become closer to adulthood, they are more likely to experience severe disease like adults do, although these numbers are still really low, as I can show you here, compared to the older adulthood. And there are many really fascinating hypotheses and explanations for why this is, and really beyond the scope of this talk, but I would really encourage you to read this paper in archives from Nigel Curtis and Petra Zimmerman for more information. And this was what we were thinking until about April last year, when in this graph here, I'm showing you in blue the number of expected admissions of children to intensive care units. And what we actually saw was this green line with this sudden surge or increase of admissions of children with a very inflammatory condition. And just to put that in perspective, these are two different scales, so don't worry. The orange is the number of hospitalizations with patients in total, including adults in France, followed 4 to 5 weeks later by this peak of young people with this inflammatory condition, just showing that this is a post-infectious phenomenon. And that led to us describing this condition called Paediatric Inflammatory Multisystem Syndrome, not a mouthful at all, with this lovely infographic from the Don't Forget the Bubbles team, showing you that these children are red and hot with tummy pain and headaches. Unfortunately, about a third of them develop severe disease where they get shocked, need resuscitation and emergency treatment, and often ending up in intensive care with heart problems, and sometimes with really quite significant bowel inflammation, which is tummy pain, and a very distinctive blood picture, which actually helps us to identify these children. These children are often negative on a swab for the virus for the PCR test, but have already made antibodies, just fitting with that epidemiological picture that this is a post-infectious phenomenon. And so we developed rapidly a case definition, which we're still calling interim, as we gather more data of these children who present with persistent fever and inflammation, and evidence that one of their organs, or often more of their organs, are affected, that we can't find another cause for it, and that they've had contact with SARS-CoV-2, which frankly, it's quite hard to find anyone who hasn't had a contact with SARS-CoV-2, so this part is less relevant these days. And this, again, from PICNET, which is the Paediatric Intensive Care community, have gathered the number of children admitted to intensive care with COVID-related illnesses over the last year. And just remembering that we screen everyone, so you tend to pick up cases where they're not actually unwell with COVID, but happen to be positive. And in orange, you can see the children who had PIMS with that peak in April, May, and small numbers here in November and December. And we're seeing a little bit of a peak at the moment, as would be expected after the big peak of cases in December and over Christmas. And we've calculated, based on serosurveillance data and surveys, that about 1 or 2 children who get SARS-CoV-2 infection are at risk of developing PIMS. Lots of research going on, which is the best way to gather really robust data. Some international observational studies looking at the best treatments that we can use. In the UK, we've got the only randomized controlled trial for treatment in children. We've already recruited, actually that's gone up to 150 in the last week. And actually, so we should have some very early preliminary data about the best way to manage these children, although our experience has really been useful. And then more epidemiological data from the British Paediatric Surveillance Unit, which will be coming out in the Lancet quite soon. And then really importantly, the Diamond study is recruiting across Europe and all across the UK to try and get better diagnostic tests for these children, really to define exactly what's happening. And the good news is that actually, even in the second surge, we think that clinicians are much better at recognizing the condition early and instituting appropriate treatment. So we're seeing a smaller proportion of these children going to intensive care. If they do go, they stay for just a couple of days, and they're getting out of hospital more quickly because we know how to manage them a lot better. I've been following the original cohort up to 6 months with colleagues across the country, and actually by 6 months, really reassuringly, the majority of these children are back to normal, and most importantly, the cardiac function is back to normal. However, a proportion of these children do have concerning symptoms similar to adults with long COVID, and these can be legion. They can pretty much affect any part of the body. These are the symptoms described in the NICE guideline, which really focuses on adults and just mentions PIMS very briefly. In the adult setting, they talk about 3 different time points: acute COVID in 4 weeks, ongoing COVID 4 to 12 weeks, and then post-COVID or long COVID in symptoms after 12 weeks with no other diagnosis. How does that fit with children? So from the post-infectious phenomenon, we have PIMS, which I've already told you about. And then there's also probably a cohort of children who've got more of a chronic fatigue-like syndrome, which is fatigue-driven with no evidence of end organ damage. But we don't know enough about this cohort yet. We are familiar with post-infectious conditions from bacteria and viruses, but also in children we have Kawasaki disease, which the syndrome PIMS originally was thought to be. This occurs in about 9 per 100,000 children in the UK, and the trigger is thought to be respiratory viruses, including non-SARS coronaviruses, which cause the common cold. And then chronic fatigue and myalgic encephalomyopathy, also possibly having a viral trigger, which affects less than 1% of all ages of the population. And the good news from a paediatric perspective is that majority of children and young people have resolution of these symptoms within 1 to 2 years, unlike adults where it can be more persistent. We don't really know how many children are experiencing these post-infectious conditions that aren't hospitalized, and that's a really key thing to understand. There's some surveys data from the Office of National Statistics suggesting 1 in 10 of all respondents, adult and children, have symptoms at 12 weeks or longer, and possibly about 10% of children, 10 to 13% of children have symptoms at 5 weeks. But we clearly need better data than this. So there are some really urgent needs. We need to know the prevalence of persistent symptoms following COVID in children. We need a consistent approach to diagnosis, management and follow-up, because I think there is a real lack of understanding of what we should be doing. And we need a case definition, which will make it easier to get children into referral pathways and assessment clinics. And we need all of these things to be represented in the NICE guidance. NHS England is working really closely with clinicians to develop a long COVID service, which should be launched quite soon. And we need paediatric specific research urgently. We are doing some research. So in a first of its kind funding partnership between Imperial, the Evelina Children's Hospital and Great Ormond Street in London, we are doing a long-term follow-up clinic study looking at imaging, blood markers, but most importantly, quality of life and cognition in children following this post-infectious inflammatory syndrome. It's so important that we understand exactly how badly they're affected and how long it persists. The ISERIC study group have developed a post-COVID follow-up for adults, and we have developed one for children, again with appropriate questionnaires taking into account educational impacts for children. This is international. And NIHR and UKRI had a £20 million launch of research funding, and we've put 2 grants in for this. And I'm just going to finish. There is light at the end of the tunnel. Children do experience less severe disease than adults, but it's crucial we support those who do have problems, and we need an urgent need for research. Thank you for listening.
Thanks very much, Elizabeth. And these slides will be available later, as will the full talk. Can we thank you very much, Elizabeth? That was brilliant. A lot of material. Can we move straight on to Rachel Wood, please? Thank you.
Thank you, Allyson. So I'm going to be talking today about the risk of COVID-19 in teachers. And I would just want to acknowledge up front that the work I'm presenting is very much a team effort with colleagues in Public Health Scotland. And I just specifically acknowledge David McAllister, who's on the call, and Linda Fenton. So since the beginning of the pandemic, Public Health Scotland has maintained a database of all individuals with COVID in Scotland. And by that, I mean anyone testing positive for the virus or being admitted to hospital or dying from COVID. And every time someone is added, a case of COVID is added to the database, we also add 10 matched individuals from the general population who haven't had COVID up to that point to act as controls. The routine health records that are within this REACT database, as it's known, don't include any information on the individual's occupation, but we recognise that assessing the risk of COVID in different occupational groups is important. So to facilitate that, to date, Public Health Scotland has been able to access 2 sources of population-based occupation data. The General Teaching Council for Scotland has provided us with basic demographic details for almost all active teachers in Scotland, and NHS organisations have provided the similar data for healthcare workers. We've linked that occupational information into the REACT database, and what that then allows us to do is to assess risk in teachers and separately in healthcare workers compared to the general working age population. And specifically, we've assessed these groups' risk of COVID requiring admission to hospital. That's our primary outcome of interest. We've also looked at severe COVID, and by that I mean COVID that's serious enough to require admission to intensive care or that results in death. And we've also looked finally at any COVID, and that includes anyone testing positive for the virus in addition to anyone requiring admission. So this slide now shows the adjusted risk of COVID requiring hospitalisation in teachers and in healthcare workers. By definition, the risk for the general population in this analysis is set to 1. And these are adjusted risks. So we've taken account of differences between teachers and healthcare workers and the rest of the population in terms of factors like proportion of individuals who are female, living in deprived areas, etc. And that allows us to make fair comparisons across groups. So what we can say, looking at the results for teachers over the whole study period, our best estimate of teachers' risk, the blue square, and the margin of error around that estimate, the grey bar, is below 1. So we can be confident that over the whole study period, that's up to the end of November last year, the risk of COVID requiring admission to hospital was lower in teachers than it was in the general working age population. If we restrict the analysis just to the period, more recent period after schools reopened following summer holiday, so that's in August in Scotland, what we can see is that for that period, teachers' risk was similar to that in the general population. And by contrast, risk has been persistently higher in healthcare workers. Now, this is a similar chart, but for the second outcome, so this is now severe COVID, and we can see that risk in teachers for the whole period and more recently has been lower than that in the general population. Risk in healthcare workers has been similar. And finally, this shows the results for the third outcome of interest. This is any COVID. Now we can see for this outcome that risk in teachers is slightly higher, about 20% higher than that in the general working age population. And that risk is entirely driven by increased risk more latterly since schools have reopened. The risk in healthcare workers of this outcome is very substantially elevated. Now, I show these results for any COVID for completeness and for transparency, but it's important to emphasize that unlike for the prior 2 outcomes that I showed, it's actually quite difficult to interpret these findings in a really meaningful way. And that's because the numbers, these results are driven really by the numbers of people testing positive for the virus. And therefore, they're really influenced by access to and uptake of testing in different groups. It is very likely that at least some of this excess risk in teachers, and even to an extent in healthcare workers, is due to higher testing of these groups, occupation-based testing. So because using the routine testing data, it's difficult to assess a teacher's overall risk of exposure to or infection with COVID, I'm going to now focus on a different approach, and that's looking at the proportion of teachers who have antibodies to the SARS-CoV-2 virus. These results now come from the CAS study. That's a large voluntary survey open to anyone working in an educational setting in Scotland. And what CAS found over the period October to November last year, based on a large and broadly representative sample of teachers from across Scotland, was that just over 7% of teaching staff had antibodies that indicated that they had had prior infection. And importantly, that 7% is very much in line with what we would expect based on what we know seroprevalence rates from the general adult population in Scotland. So lastly, I just want to touch, there is of course information on risk of COVID in teachers from other parts of the UK as well. The ONS, through their large-scale COVID infection survey of individuals, randomly selected individuals, has reported for England that the proportion of adults either with COVID or with antibodies to the virus, the proportion of individuals within education settings is similar to that in other occupational settings or the general population. And the ONS has also reported on mortality from COVID by occupation for residents of England and Wales. And they have shown that teachers are at significantly lower risk of mortality from COVID than the general working age population. And with teachers' risk being generally in line with that of other professional groups, except healthcare professionals. So just to summarize, I think the range of information that's available allows us to give a really reassuring message to teachers. There is quite strong evidence now that teachers are at similar or lower risk of serious illness or dying from COVID than the general working age population, and that finding persists, including during when schools are open. The results, there's generally more uncertainty around teachers' overall risk of infection or exposure to the virus. Again, findings based on population-based surveys are reassuring, suggesting teachers' risk is very similar to that in the background population. Results of analyses that rely on routine testing can show some increased risk for teachers, but some of that is likely to reflect their higher access to testing. So just to finish, whilst I want to emphasize that this is a very reassuring message for teachers, I don't at all want to give a trivializing message. And I recognize that a similar risk or even a lower risk is not no risk. And essentially the message is that the risk of COVID in teachers reflects the background risk in the communities and populations in which they live. So the higher our community rates of transmission of COVID, the more teachers and everyone else will become infected, the more opportunity to import infections into school. And as we've heard, although schools don't seem to be very effective settings for onward transmission, that does increase the possibility of transmission within school. So I'm sure we all are very keen to see schools open. We want to see schools open consistently with minimal absence and illness among staff and children, and maintaining low community transmission rates will be an important part of us achieving that.
Thank you.
Thank you very much, Rachel. That was brilliant, and you kept to time. Phil, can I ask one question or not?
If it's quick, you can, yes.
Well, I suppose the questions are twofold. Anybody? Have you done any difference between primary school and secondary schools? Is there any difference in risk of infection and severity of disease? And what about the effect of the new variant, Rachel?
I would like to bring my colleague David into the discussion. So if he wants to help with the questions, away you go, David.
So we didn't see any difference between primary and secondary. We did look, obviously, but no, we didn't find any difference in associations. We've not properly looked at the new variant yet, but that's absolutely on our to-do list.
Yes, and we have to recognise, I mean, this today is all about recognising uncertainty. So all we can show is the information we have at the moment and keep our minds open and keep looking.
Thank you. Thank you, Rachel, Liz and Allyson. We're trying to stick to time. I notice we've got hundreds of questions, which always happens. There's so many brilliant questions we could answer, but we'll try and mop some of them up at the end. Thank you for that. We're going to move on to the impacts now of school closures. And I'd like to welcome Caroline Relton from the University of Bristol, who's going to chair. Hello, Caroline.
Hello, Phil, and thanks very much for that introduction. I'm going to move straight on and hand over to Elizabeth Gilpin, who's a head teacher of one of the larger secondary schools in Bristol, which also has a sixth form, very diverse school. And so Elizabeth is going to give us the teacher's perspective on the impact of school closures. Over to you, Elizabeth.
Thank you. So the first thing to say is that there's quite a lot of oversimplifications in the media, and I want to pick some of those up. Firstly, schools are not closed. There's real-time remote learning going on. Critical worker children are on site, and children who are vulnerable, perhaps because of their special needs or their home circumstances, are also on site. So my teachers are teaching their normal timetable. Some are on site so that they can demonstrate science or DT work and access equipment, but most are working from home. On site, our learners are covered by support staff in ICT rooms in small bubbles of 10 or less, accessing their normal class teacher remotely. Or if they have special needs, they're supported in a smaller group with a learning support assistant. Our off-site real-time lessons do all the normal things that lessons do. Assessment, behaviour, content, differentiation, and promoting high engagement. The lessons still very much have our school values at heart, encouraging children to be questioning, to be creative, to be resilient. The few students who do not engage are followed up by our pastoral staff to see if they have an IT problem or another barrier to learning. But so far, I've been delighted since the start of January with the really high levels of engagement and positivity of our children. The second myth is that lockdown 3 is the same as lockdown 1. Now, this is not true. In lockdown 1, we were not able to do real-time learning because of student ICT access and also school ICT infrastructure. So we had a mix of paper-based and work on our virtual learning platform. The third thing is that all closures are not the same. The method of the closure matters. For primary schools, they were put in a very difficult position. They were open one day and the next day they were meant to flip to remote learning with no time to prepare. And preparation is really important. There's a kind of myth out there that teachers are superheroes. Now, in the Marvel Cinematic Universe, there are two kinds of superheroes, those for whom it is innate and those who use the science together with amazing organisation and their intelligence to be superheroes. And we're definitely in the latter group, that we need time for preparation and organisation. One of the key things is our communication with parents and students, because that has to be really calm and reassuring and holding. And I think that that's an important filter that schools are providing to provide that kind of comfort and sense of security. The fifth myth, I think, is that schools being open will solve psychological distress for young people. Now, obviously, schools being open is better than closed, but our country is going through a pandemic. And so there are so many more bereavements and ungrieved losses. Parents are more anxious, perhaps because of potential job losses. And children will be soaking up all this trauma. So we need to be caring about those things now while schools are closed and doing our best to support them. Children need control, stability and nurture, and to know that adults are trustworthy and respect them. They do not need false promises. I want to think about the positive impact of school closure. The big thing is to make the now the very best it can be. It really can be good. And what we're seeing is a lot of positivity amongst our young people. We also need to use this time to prepare the best way to open. For example, I'd like lateral flow tests that could be done at home, not used as a magic moonshot. I'd like information out there about the wider range of symptoms, tummy, throat and headaches. I'd like to be certain that the government will use school resources once. You can't use the school hall to do both testing and to do mini exams. Context, as we've heard from Alasdair, is really important. Infection levels in the locality need to be low enough. 50 cases per 100,000 would mean about 1 case in my school. That's perfectly manageable. Vaccination is so important because the 50 to 70-year-old age group are the granny and granddad age group for my children. We need to accept that sometimes year group isolation is the right thing to do if it's accompanied by good quality remote education. It's sometimes less disruptive. And we need to have the flexibility to bring back small groups of year 11 and 13 so that we can really support their achievement. So in summary, sadly, there are no easy answers. We really need to make the most of now and invest in that. And we really need to use this time to prepare well for how we bring children back. So what I would strongly advocate is that at the heart of all of this is our respect for the children, not as a political win, but for their resilience, their creativity and their self-sacrifice. We need to invest in their education both now and into the future.
Thanks very much indeed, Elizabeth, for that really personal and heartfelt description of what it's really like for schools. I'm going to move on and ask Sunil Bhopal to present now. Sunil is a paediatrician from the University of Newcastle, and he's going to give his perspective on the impact of school closures on children. Sunil.
Thanks very much, Caroline. That's much appreciated. So I'm a paediatrician and an academic paediatrician, mainly working in the community in the northeast of England, Newcastle University. I've been asked to talk about the consequences for children and young people of school closures, and I thought that my first slide might just point out something that's quite obvious, that this is not all about schools and it's not all about education. So at the end of April 2020, this is us writing a very short letter in The Guardian saying, you know, there's a fundamental question here. There's been an appropriate governmental prioritization of the needs of adults and particularly the elderly in danger from COVID-19, but who's responsible and accountable for the best interests of children and young people? And we felt at this time that there was a stark lack of focus from government, but also in public discussion of the effect of COVID-19 on children's lives, not just health, not just medicine, not just education, but across where children live and what they do, health, education, social care, justice, and poverty, as we wrote. And I have argued through this period that we've been causing great harm in many ways to children through our pandemic response. And the question that I'm asking is this harm justified by the benefits brought about towards pandemic control? And I can't answer that question, and I don't think that any one of us in particular can, but I think it's an important question that we should have out there and we should be discussing. So as we've heard today, children are minimally directly affected by COVID-19, but they're shouldering, I'm arguing that they're shouldering a huge burden of the restrictions, and I will present some data to hopefully back that up. And schools are at the heart of childhood, and I think, it's just wonderful to hear from a head teacher today, because who knows better about children and childhood than a head teacher. So I think that's absolutely right. And schools matter not just for education and learning, but for everything else. Children need children. They need to spend time with them, socialization, interaction. We've now got to the stage where, amazingly, it's illegal virtually for primary school age children to meet up with anyone outside their household during this third lockdown. And there's huge inequalities here. Those who live in smaller homes, flats perhaps. Stay at home sounds so easy for some of us and much more difficult for others, particularly those without outdoor space and so on. We talked a lot about the differences between younger children and older children or young people. And, I think it's just really important to remember the vast changes that are going on in teenage brain development, the importance of that adolescence period for developing into adults. I won't talk much about the learning loss, except to say that this was estimated at something like 3 months, much greater for those who were already most disadvantaged when the children came back to school. Most children came back to school in September, and this is now continuing. And the reason I just quickly corrected myself there on most children, and we've heard already that schools have not been closed for much of this time, which I think is right, is just to be clear on what we're talking about. So here's a graph showing the proportion of school children attending school. So through April to June, very, very few children in attendance, something like 5% to 10%. And then even through June and July, this never really got above the 20% mark. So like I say, it's not all about learning. So it's hitting health, well-being, relationships really hard. And so by May 2020, 2/3 of primary school pupils were saying that they were lonely. Well, it's no surprise. 1 in 6 children and young people suffering from a diagnosable and actual mental health condition. We're not just talking about small things here. The proportion achieved, we know we have a childhood obesity crisis. The proportion achieving 60 minutes of exercise per day, dropping from around half, which is not very good, to 19%, even worse. And all of this is much greater in the poorest and already most vulnerable for various reasons. The stories are horrendous, the stories from my pediatric clinics, and I will sort of lay out a few little excerpts, but it's very difficult to sort of talk about them in any detail because of confidentiality reasons. And this is all on the background of this period of time increasing family vulnerability, which, children are not lone actors. They live within families and live within communities. And even before the pandemic in this country, we had over 2 million children living in dire situations of domestic violence, parental ill health, physical and mental, alcohol and substance misuse. And this has all got worse during the pandemic. So parents are under tremendous strain, and this has been an incredibly difficult period. Here's a little graph showing, we talk about vulnerable children having access to school. Well, some of the most vulnerable children here, I've pulled out the figures of those with an education, health and care plan, EHCP. And we can see that through April, very few of those children attending school, always less than 10%. After Easter last year, maybe getting up towards the 1/3 mark, but certainly not higher. And here's a little graph showing food insecurity. We've heard a lot about that in the media recently, the terrible situation that families are in with regards to accessing food for their children. Schools have a huge role to play in the child protection system for identifying the most at-risk children, described as the eyes and ears. So this is an early letter from us in the Archives of Disease and Childhood Journal. Child protection referrals dramatically decreasing up here in the northeast of England. This is at the same time that we know that the harmful situations are increasing. So 16% increase to Childline, but 20% reduction in child protection assessments, 30% reduction in children coming into care. And the Children's Commissioner and Childline and so on have picked up on this. Here's the Children's Commissioner briefing: too many at-risk children are still invisible to social care. The Children's Commissioner for England, that is. Big question that gets put to me, well, they'll be fine, they're resilient, they'll be okay. Maybe what doesn't kill you makes you stronger, these sorts of discussions. And I think the data is coming out thick and fast now that can really say, you know, people have these stories, people tell these stories, but when 1 in 4 young people are saying that they feel unable to cope with life, I worry. And they're thinking about not just the immediate time, but they're thinking about their future. And as Anne Longfield said, in many decisions taken over the last 6 months, children haven't been at the forefront. This is not just important for now, but it's of lifelong implication for individuals, and that has implications for all of us as a society. Just to talk a little bit about individuals, and these are sort of amalgamated stories, so none of them are sort of individual people. You know, if you think about if an 8-year-old with autism spectrum disorder with an EHCP, a lot of schools didn't have the capacity to look after children in this category, or children like this, through March to May 2020. So they were not able to go to school. This child attended from September to December, but had 3 14-day isolation periods. So having to spend time indoors without seeing anyone. And then again in January 2021, there's a real lack of staff capacity to look after some of the most vulnerable children who we hear from government are those who should be in school. Here's a 6-year-old whose mother says the child is withdrawn, can't get out of bed, and has stopped eating. I didn't know that young children could get depression. Here's a 15-year-old with depression, self-harm, I've got nothing to live for. And they're at home alone because their parent needs to go out to work. Yes, they're technically allowed to go to school. Okay, I can see I've got a minute left, but not actually able to access schooling. And in June 2020, the Royal College of Paediatrics and Child Health got so alarmed at what was happening as the prevalence fell and most children were not getting back to school. Here's the front page of the Times: doctors demand schools reopen, trying to strike a sort of balanced note. So saying that the risks of keeping children out of school is high, balance against the difficulties of pandemic control. But what we could see is that clothes shops reopened, theme parks reopened, and pubs reopened before schools. So in the third lockdown, there is change. Schools are much better prepared, communication's much better, but we're already seeing eating disorders and severe mental health concerns. On the 21st of January, 5% of secondary pupils were in school, 21% of primary pupils, and more in special schools and those who are vulnerable and with a social worker. So we are seeing change. Is it all doom and gloom? Well, I've described lots of it, but there are positive lockdown impacts. We need a recovery plan and investment. There still is an opportunity to put children and young people first. And I would echo the words of the head teacher, Elizabeth, who said that we need to stay away from these dichotomies, open, closed, and certainly we need to stay away from safe and unsafe. I have left a question there. What are we going to do next time, describing the next pandemic? But I'll stop there. Thank you very much.
Thanks, Anil. That was really clear. I'd like to move on now to introduce Bruce Adamson, who's the Children and Young People's Commissioner for Scotland, who's going to give us a short viewpoint. Thanks, Bruce. Over to you.
Thanks, Caroline. I've got the best job in the world as Children and Young People's Commissioner for Scotland because I work directly with children and young people to promote and safeguard their rights. But this has been the biggest human rights crisis that we've faced in a very long time. And it isn't the start to 2021 that we hoped for. The optimism from vaccines has been really overshadowed by the rising numbers and the necessity for further restrictions. Children being away from schools and early year settings has a devastating impact, not just on their right to education, but on their mental health and development. And it's been a concern that we've been raising since March last year. In April last year, the UN Committee on the Rights of the Child warned of the grave physical, psychological impacts on the pandemic of children, and we're already seeing those come to pass. And Sunil and others have done a really good job in setting some of that out. But the UN Committee and us as children's commissioners have called on states to take a rights-based response and to focus not just on the public health implications, but on the broad framework of human rights, including economic, social, and cultural rights. Because while closing schools and nurseries may have been necessary to protect life and public health, more needs to be done to protect children's rights when they can't access school-based support and community-based support. The children and young people that I speak to, they understand the important role they're playing to protect public health, and they'll be doing a great job. That resilience, creativity, and self-sacrifice that Elizabeth spoke about over the last 11 months to stick to the rules. They've even talked about some positives, about spending more time with families and some community solidarity. But there are real huge human rights concerns. Parents, carers, teachers, and early years practitioners have been doing a really amazing job, but emergency home learning isn't a substitute for being in class. While we've seen some really good improvements, the issues that Elizabeth and Sunil laid out are stark. And so children and young people's right to education, to health, to family life, together with friends, have all been infringed by the restrictions. And those already most at risk are suffering most: disabled children and young people, care experienced children and young people, young carers, and particularly those experiencing poverty. And noting that more children are now living in poverty, suffering poor mental health, and dealing with bereavement. So this is a human rights crisis. Schools aren't just about lessons, and the purpose of education is to develop children to their full potential. And school communities play a really vital role in support and places of safety. So we've got to do more to ensure children's rights are properly fulfilled, and we need to use available resources to the maximum extent possible. It's absolutely essential we focus on health, mental health, and also the recreational and other impacts. Time doesn't allow for too much elaboration, and I know we're very short of time tonight, but I think really importantly, we need to focus on ensuring that children aren't discriminated against. We need to make decisions in their best interest. We need to involve them in decision-making, and there's been a real failure to do that. And we need to focus on their rights, including the highest attainable standard of health, an adequate standard of living, a warm, safe house, regular nutritious food, benefit from social security, benefit from state support to parents, an education that develops the full potential, and being able to access information and socialization. So digital access is so important. And we really need to focus on making sure we use all available resources to the maximum extent possible to secure these rights. And so some real failures in terms of involving children and young people in decision-making on things like exams, on things like remote education, and on things like child poverty. I commend in my last few seconds the work of the European Network of Ombudspersons for Children and the World Health Organization Technical Advisory Group on schools, which I think are really powerful. And close simply by saying that while the majority of children have been excluded from schools, and it's really important that those in vulnerable situations are still in schools, their worlds have really shrunk, and the impact across those different age groups has been profound. And we have to realize that children experience time differently, and we need to involve them in decision-making, and we need to prioritize their rights when we're using available resource to the maximum extent possible and taking a human rights response to all of our decision-making. Thanks.
Thanks very much, Bruce. And I'll hand straight over to Haroon, who is the Director for Evidence for Children's Commissioner of England. Okay, Haroon, thanks.
Hi, thank you. Thanks very much for having me on, and thanks very much to Sunil and Bruce for giving excellent presentations that have made my time management task a lot easier by covering off the things that some of the things that I wanted to talk about, and now I don't need to repeat. I agree with everything that they said. I've got very little time here, but I can focus my my remarks a bit more as a result. And what I will talk about is what we've learned from speaking to children, our engagement, our rolling engagement with children over the last year or so, and in terms of the impact of school closures, going back to school, but also the impact lockdown itself. In September, we ran a survey, a national poll of children to get their views on going back to school. And 70% of the children that we in the sample said they were excited to be back at school. 80% amongst those who are of primary age. Half of children were worried about how they're going to catch up with the schoolwork that they've missed, and 2/3 of them were worried about what they'd have to do if they had to self-isolate, or if there was another local lockdown, or if their school closed. It was really interesting to look at the themes that kept on surfacing in the free text and the qualitative responses. Children spoke about a sense of normality, a sense of routine, having structure again in their lives, being able to see their friends, being able to speak to a teacher and learn in person and actually ask a teacher a question and have something explained to them. That's not to say it was all perfect. Children were worried. A lot of children were worried about whether it's safe in school. They were worried about whether the guidelines would be adhered to, whether the distancing and the hand washing and the one-way systems would be adhered to. But overall, actually, when we looked at the worries that children listed, that the top worry was how they were going to catch up with all the work that they've missed. And the second highest worry was was the risk of school being closed again. And the situation that would put them in, or the risk of having to self-isolate. And unfortunately, children are now in that situation again, the overwhelming majority. And when we speak to children, they talk. This has been discussed already. They talk about how it's affected their mental health. Children have said to us they feel like a different person. They feel like it's affected their sleep. They're not just they talk about the effects of just putting school to one side for a second. They talk about the effects of the things outside school that they are no longer able to do, things like play football or play tennis or cricket or go to youth clubs, all of these things that were their escape from home and from school, which they don't have anymore. In regards to school, some children do very well with home learning, but we hear again and again how children have really struggled with it. Especially those who need a teacher to explain things to them. Sometimes what children tell us, and this may not be the case universally, but a lot of children mention that they receive a work pack via email, and they're just left to their own devices. Now that works for some children, but some need things explained to them. They're not used to that independent, self-directed study, especially younger children. Those children who are in more deprived households and tell us about how they've given themselves a headache trying to watch lessons on a phone screen with a crack in it. And then there's the concern about exams. A key theme that's cropped up this year is the anxiety that children have had about exams, not knowing whether they're going to go ahead, relentless pressure from revising for exams, and having to treat every single mock test as if it's the final exam, because it could be. It could be the one that, and it could be. And now that we know that exams have cancelled, the last test that they did is going to be their final one. That will be the basis of their final grade. And of course, doing all of that while having missed large chunks of the syllabus. Children, another interesting, we talk a lot about learning loss exams, but actually an important thing that we miss and we discover from speaking to children is the impact, is that they're worried about their future beyond school as well, not just in terms of exams. Children tell us that internships have been taken away. They can't get an internship anymore. Apprenticeships, if you look at the data on apprenticeship numbers, those have reduced drastically. Children and young people can't get one. So some of those very first rungs on the career ladder have been taken away. Finally, children talk about how they feel like they've been blamed for COVID. This is really interesting, especially in the second wave in the autumn when schools are reopened. Children were told to go to school. They're told that it's safe to do so, but then they felt like they're being blamed for spreading it simply by going to school. Now, children have always feel like they're unfairly depicted in the media, but that's been accentuated during the pandemic. The final thing that I want to talk about, just in the last few seconds I've got left, is how we empower and engage children throughout this pandemic. They don't just feel scapegoated; they also feel ignored. Did you know that you have to be over 18 to submit a question to the Downing Street press conference? I just checked that, and you do. When we discovered that, we thought that can't be right. We wrote to the government and asked if they would change it. When that didn't get anywhere, we decided to do our own SAGE press conference. So working with the other commissioners of the UK, including Bruce, and members of SAGE, we put on our own event exclusively for children where they can ask the scientific advisors their questions about coronavirus. And a recording of that is available on our website. And we're returning to this idea again. Anne Longfield, the Children's Commissioner, said that we need another Downing Street press conference where the Prime Minister could take questions from children and parents about the latest lockdown and when schools might reopen. The very, very last point I want to make, apologies for overrunning, is that it's not just about voices that we need to reflect in the debate. We also need better data on children. We've got what I call decision-making by dashboard. In the top of government and the cabinet office, they've got endless dashboards and sit reps with live up-to-the-minute data on the R number, cases, deaths, intensive care, pressures on the NHS. What we don't have is the same quality of data on pressures of children's lives. Learning loss, isolation, mental health, the stress at home, the damage to their prospects, the damage to their play, their well-being, their sleep, their physical health. And senior people in government tell me, look, we're worried about all of these things, but we can't measure them, so we can't quantify them, so we can't really consider it. And so we can't win the argument because the data that we have got is overwhelmingly on one side of the argument. It's a great example of the streetlight effect. The drunk person who's lost his keys and he's looking for them under the streetlights, not because that's where he lost his keys, but because that's where the light is. And so,
interject there, Haroon, I think we're running perilously short of time,
right.
So if we could draw that to a close, and just to pick up one of the very important points you made there in your closing remarks around data and the need for data, perhaps I could ask Sunil if there are lots of questions coming through from the audience about the quantifying these detriments in mental health in children. Do you think it's possible to come up with a series of quantified statistics that tell us how bad the situation is compared to the normal non-pandemic times?
Yeah, I think that's so crucial, isn't it? And somebody asked absolutely the correct question, which was, you said 1 in 6. What was it before then? And I think that's absolutely right. Those data do exist, and we should talk about them. We have to acknowledge that things were, in many areas of child health and well-being, were terrible before the pandemic. So it's terrible to even worse than terrible, whatever that is.
Thanks, Sunil. And I'd like to ask Elizabeth a question about the role of the broader suite of symptoms that you alluded to in your talk, and how important you feel it is, or not perhaps, to take account of those additional symptoms rather than just the sort of the smaller cluster of cardinal symptoms that are recognised to be indicative.
We found them really, really helpful. So during the first term, up to the October half term, I only had to disrupt 1 year group's education because my parents were made aware of the World Health Organization range of symptoms. And we found about half of our cases it actually didn't start with any of the classic NHS symptoms. They started with gastrointestinal problems, sore throat, headache, blocked up nose. And actually, by parents keeping their children off when they had those symptoms, it had 2 positive spin-offs, less COVID on site, and it also meant that my staff were really healthy. And so people got their right teacher because they weren't off with other things as well. And we're part of the COMIN study, which Caroline's involved in. And when Caroline did a sample of our year 8, 10, 12 and our staff, we didn't find a single case when we tested them. So it just shows that actually using the symptoms is another useful armoury for keeping our schools safe on their return.
And one final question for the speakers in this session, and that's perhaps on a more positive note. There's been tremendous parental engagement by virtue of the fact that parents have often had to homeschool. Do you think there's a way of harnessing that parental engagement going forward post lockdown to enhance the education that the children get?
We've been so impressed with the way our parents have engaged. It's opened up a lot of really good dialogue, and it feels like we're together as a team in a way. I mean, we were before, But now when you're going, you know, you're being in touch about really specific things. So I think there's a good set of relationships to build on for the future there that have deepened through this process.
Thank you. And I think I'd better hand over to Phil so we can at least try and keep to time. Thank you. Thank you all.
Thank you, Caroline. That was a fabulous session. Moving very quickly on, our final session is on international perspective. So let's hand back to our esteemed chair, Fiona Godlee. Hello, Fiona.
Hi, Phil. Thank you so much. And thanks so much for everything people are doing on this great session. I've got international perspectives now, 4 wonderful speakers from the United States, Norway, France, and then a roundup from Europe. So first of all, let me hand over to Ibukan Akinboye, who's Assistant Professor of Paediatrics at Duke University School of Medicine, specializing in infectious diseases. Ibukan.
Thank you very much. Thank you, everyone. I am going to very briefly just walk through and just move my control here. Just walk through our experience, certainly not representing the entire country. As you're all aware, we certainly have our divisions here, but just sharing the collaborative that occurred through my colleagues, and not speaking for everyone, just representing Duke University, University of North Carolina, and then some of this has been funded by the NIH. Our goal was to ensure that we created a data-driven collaborative where we were trying to provide evidence-based decision-making to superintendents that may translate as administrators or leaders within the education sector for our European countries, and then just delivering educational resources. We're not policymakers or making the recommendations, but we very quickly realized that we needed some clarity around all the noise associated with opening, closing schools, or just having in-person education when and if it was safe. We also had an app associated with this collaborative to help with contact tracing. So I wanted to just walk through the most recent development with this that's called the ABC Science Collaborative. The most recent development has been a publication in Paediatrics that was reviewing secondary transmission within schools. And for some context here, we are working in a southeastern state in the United States, and we're also working now across the entire country with some of our colleagues. Within this state, we have a number of school counties, and then within those counties, you can have smaller school, just school infrastructure and school, the way schools are run may be slightly different across the board. But in this context, we had 11 districts participating in the collaborative, and they agreed to track incident and secondary transmission. The definitions here, I won't belabor the points, but primary infections were those that were just identified in the community. Secondary meant that there was a potential spread in the school setting. Local health department staff were helping with adjudicating the cases, and due to the setup of this collaborative, we were able to meet with the superintendents, which are the school leaders for that district, weekly to review lessons learned and have them just create a setting where school leaders could learn from each other and iterate the process each week. Because this is an international platform, I wanted to, again, just set up the context here. This data only occurred in Plan B, which was just called the hybrid setting, where there were reduced capacity in the school building as compared to what it was prior to the pandemic. Masking was required for all children over the age of 5 initially, and then that has dropped down to over the age of 2. And there were a number of things, including cleaning, hand washing, some ventilation adjustments, including opening windows or having lunch outdoors. This was in the fall for us and certainly was a lot warmer. So there are not a lot of caveats here that we don't have enough time to go through, but certainly it will help with understanding the context of the data I'm going to show next. What did we find? So this included over 90,000 students and teachers, varying demographics across racial and ethnic groups. We did find 773 community-acquired cases. The community rates at that time ranged from about 200 per 100,000 population to as high as 900 per 100,000 in the population for a 2-week period. So we saw a wide variety of rates in the community, found some community cases, which is not shocking. Schools are just a reflection of the local communities, but we saw very few, not zero, very few secondary cases. And it It occurred in kindergarten to as high as, for us here, grade 12, which is about the secondary school, high school level, but no instances of child to adult spread. I mentioned a lot of the caveats here. We did have some missing data in the number of people quarantined, but amongst those that reported quarantine numbers, it was over just under 3,000 people. So among those that were quarantined, we found this rate of 1.17% that became positive, very low rates overall. And none of the districts with missing quarantine denominators reported any secondary cases. So it's a quick walk through all of this. I think I just wanted to highlight that we've made decisions in the absence of data. Our goal here was to ensure that we can start to have data-informed decision-making. When we did see cases, oftentimes it occurred, at least the one cluster here was defined as cases, more than 5 cases with an epidemiological link. In that context, it was in a special needs classroom and in the younger age, so in the pre-kindergarten where they were not masking. In both of those settings, we adjusted and we haven't seen secondary spread. So it is possible to have in-person education safely during a pandemic. It's certainly not the panacea for all of our problems, but we should have ongoing discussion. Thank you very much.
Ibukan, thank you so much. That was a fantastic, concise summary, very important data. Next, we have from Norway, Margrethe Grev Isdal, who's a paediatrician and senior physician in vaccine preventable diseases at the Institute of Public Health in Norway. Margrethe, over to you.
Thank you. Let me just try to share my screen. Let's see if you can, do you see my screen now?
Perfect. Just put in present mode.
There we go. So first of all, I just wanted to thank you for giving me this opportunity, and on behalf of all my colleagues here in Norway. The map here on the right shows our country, which is a small country compared to, in population-wise, compared to many others, 5.4 million people. Our main area, our main population density is around the capital, where we also have had the highest number of cases reported, nearly 60%, which is shown here in dark blue. And because of this very diverse epidemic situation, the lighter blue colors show the lower incidence. We've also had a strategy since June that that measures should be locally implemented and not on a nationwide basis. So this is how the pandemic has rolled out in Norway. Along with many other countries in Europe, we closed schools along with a lot of other strict IPC measures in March 12th. And then we gradually started reopening by the end of April, which was a lot earlier than many other countries, but on the downward slope of the incidence and prevalence level. Started out with the younger age groups, the kindergarten, nurseries, and lower age groups in schools. And then we reopened for the older age groups in primary schools along with secondary schools. And we didn't see any increase. And one of the challenges we had in May was that there was a very low incidence, but our measures, there was a lot of concern when we reopened. And so we had to have a very detailed guidelines on how to implement IPC measures in schools. And it turned out that they were actually quite strict. So couldn't justify it with the low rates we had when there was to have so little in-person education. So when we started out with making a strategy that we called the traffic light system. I'll come shortly back to that. But when the cases increased in the end of October and beginning of November, and we started local outbreaks, it was time to implement this system. So from May to November, we were at the yellow level. And this traffic light system has allowed us to kind of increase the measures in schools, but keeping them open. So if we compare to the previous speaker, our red level would be the yellow level that they probably had in North Carolina at the time. So the red level is more when you have to have more restrictions. We had to have smaller cohorts of students, about half class sizes, and avoid mixing of teachers in different cohorts. For the older students, especially, there has to be a combination of distance and in-person learning. while when you're at the yellow level, we allow a whole class, which could be up to 30 pupils in one classroom at the time. And for the older students, we still have full classes, but have permanent seating so that they don't mix unnecessarily, and also advise that they should keep distance outside of classrooms. So for all levels, we haven't implemented the green level anywhere in the country yet. We've been at the yellow level and at the red level, but we have also had had a lot of communication around staying home when sick and implementing hygiene measures. And we're one of the few countries that have kind of been able to avoid masking in schools, neither for teachers nor pupils at any age. So how did that work out? I bet you're trying to guess how that rolled out. And so what we saw was that during the fall, we have the weeks along the x-axis and the age groups according to each school level along the y-axis. This is inspired by the next speaker who showed a similar heat map at a webinar in October, which made us make one for Norwegian setting as well. We saw that in areas where there were an increasing incidence, we had to increase the measures and go over to the red level. And so in the beginning of November, week 44, the red level was implemented for the upper secondary and also some lower secondary schools, which are age groups 16 to 18 for the upper secondary and 13 to 15 for the lower secondary schools. And what we saw was that even keeping schools open with about 50% in-person learning and 50% distance learning, we were able to get the rates down. It was at the same time we did have other measures implemented in society in general. So there is a combination of the effects here, but what we see is that it is possible to get the rates down among students even if keeping schools open. And what you really don't want to have is a Christmas holiday, because what we see in week 52 and 53, when schools were out, that we did get increasing levels when they kind of socialized, and either with each other or with other family members. Even though we did have advice to keep the number of contacts at a minimum, there was an increase in social contacts during this period, and also more traveling. And so the first over New Year's Eve, we saw an increase in rates in the age group, but reopened on the red level in week 1. And there was also then a decrease in cases when they came back to school. So our experience is that it is possible to keep schools open with 50% distance or in-person learning for the older students. And for the younger students, we've kept the yellow level throughout fall. And been able to keep schools open with more or less full classes. Finally, I just want to share one picture with from some colleagues that have done a very important study, which is one of the few prospective contact tracing studies that has been done in the school setting, where a child is an index. And this is also done at the yellow level, normal class sizes, no masks. So when a child is identified as an index, they went in and started to trace the contacts for each student, both children and adults. And 9 of these 13 children were asymptomatic, and the 4 last ones had very mild symptoms. So they were at school in the infectious pre-test period. Out of the 292 contacts that were tested by PCR, a saliva sample, as soon as the index was identified, and then again at the end of their quarantine period, which is 10 days, we can see that we had very few other primary cases, and one of these children also had a shared exposure with the index child. So only 2 children were identified as primary cases at the first test time point, and 1 adult, and we didn't have any secondary cases at all. So in conclusion, the data are very reassuring regarding transmission from children, and underlines the importance of keeping measures involving children at the lowest level possible. Thank you.
Margrethe, thank you very much indeed for that wonderful presentation. Moving on now to France, and we have Arnaud Fontenay, epidemiologist, director of the Pasteur Centre for Global Health Research and Education, and a member of the Scientific Council, helping to guide President Macron in his response to the pandemic. Arnaud, thanks for being with us. Over to you.
Thank you very much, Fiona. So I'm going to give you some thoughts about the French perspective. First of all, you have to realize that our president and our Minister of Education are very much in school opening. They made it very clear. Our Minister of Education said that we would have to go over his body if we want to close schools. So the message was from the beginning, well, pretty straightforward. Still, during the first lockdown in March, we closed schools as we had shut down the entire country. But at the time, we had to discuss the reopening in May. As a French Scientific Council, we were a little bit hesitant. I myself had coordinated 2 surveys, serological surveys, retrospective, looking at schools in the city, small city north of Paris, where actually probably the epidemic began in France. And it started in a high school. And there, in the middle of the flu epidemic in February, nobody knew it was COVID. They all thought they had common respiratory viral disease. And in the high school, the attack rate ended up being 40% among the students, 40% among the teachers, 50% among the non-educational staff of the school. And the secondary attack rate from the high school student into the homes, nobody taking any measures because they didn't know it was COVID, was 10% with the parents and 20% for brothers and sisters of those high school students. We also went to primary schools, and there we realized that there had been 3 introductions of symptomatic children in primary schools, and in the classes where those symptomatic children were, 30% of the class was seropositive, whereas for the remaining of the school, it was 10%, although it had spread completely asymptomatic in those 3 classes where the initial first 3 symptomatic kids had been introduced. So with that in mind, we were not very happy in reopening the schools, but our president said, yes, we are going to do it in May. And he was right. After all, he's the president. And he was also right because there was a very low community transmission in France in May and June following the initial lockdown. And as was already explained, if you have low circulation of virus in community, you will have low circulation of virus in the schools. And that goes on with the school holidays in the summer, and then the September, we resume school. Quite tough restrictions. We put masks to all kids from the age of 6 and above. And things go okay. I mean, there are a few outbreaks here and there, but nothing really major. And I think our media would have been very happy to pick on any if there had been. November goes also pretty well. You know that we had our second wave, like many other European countries. We start lockdown, but we keep the schools open like Ireland did in October. We had been watching them, and we felt that the sort of mild lockdown they had with the school open was a good idea. We do it, everything went well. So we feel like after all the schools can stay open, and that's not, I mean, that's compatible. If you put the right restrictions in place, it works. I since have been involved in coordinating a case control study, which have taught us a number of interesting lessons. We recruit cases who are adults, and we ask them in the 10 days before your onset of symptoms, what did you do and where do you live and blah, blah, blah. And the same with controls which are matched on age, gender, region, population density, and date. And what we realized is that, first of all, you have an increased risk of being infected for any additional person living in your house. And in multivariable analysis, taking into account this, you also have an increased risk of being infected if you have a child in high school, a child at college, a child in kindergarten, and a child in a daycare center or assisted by a childminder. But you don't have an increased risk if you have a child in a primary school. And we also found that there was a lower risk for teachers compared to the reference category, which was the people, senior public civil servants, who have an average risk altogether. So this notion that having a child at school, except from primary school, making you at more risk of becoming infected is something that I keep in mind, and that still puzzles me a little bit. Anyway, now we are in early 2021, and all what I told you was okay with the good old 2020 virus that we already missed, because now we have this nasty B117 coming, and we see this variant coming up in France. We are now about 10% of all the positive cases are with this B117 variant. And we have major question for the coming weekend, as you may, well, that's probably true for many other countries, but we have to decide on tough measures or not. And I really cannot tell you what decision would be made, because I think that school is going to be at the center of the discussions. This would be probably the last thing that our president or Minister of Education will agree to close, but we are very concerned with now that we see the variant coming up, and we have seen what happened in the UK, in Ireland, in Portugal, where only after strict lockdown and school closure, they managed to get control. So, well, watch French TV if you want to have the response for what's going to happen for France. Thank you very much.
Oh no, thank you. We're all glued to Call My Agent, 10%. So we're all watching French TV via Netflix. But thank you so much for that really, really good, concise and high-level response. We're moving on now to our fourth and final in this session. Very pleased to welcome Jennifer Cousin-Frankel, who's going to give us a view from Europe and United States. Jennifer is a staff writer at Science Magazine. Jennifer.
Thank you so much. Thanks for having me. And yes, I just wanted to talk a little bit about, very briefly, some of the reporting that we've done over the last 11 months and sort of how it pertains to today. So I'm a staff writer for Science, and 11 months ago, back in early March now, started reporting on schools and COVID. And much of the reporting was done in collaboration with a colleague of mine in Berlin, Gretchen Vogel, and one or the other rest of us has actually spoken with several people on this webinar. So it's nice to see you in person. So our let's see if I can. There we go. So our first stories, we're asking these very kind of basic, sweeping questions to give a sense of how little we understood. Though some of these are still questions we're asking today. And then back in the early summer, we tried to look at lessons that may have been learned from openings of schools in the spring. And so we looked across about 20 countries and how they had opened and how that had gone for them. And really tried as best we could to dispassionately consider the available data. That has been our approach all along. Now, then came the fall. And as all of you know, in the fall, cases started surging and there were far more widespread school reopenings. So we had to ask ourselves, did what we had covered earlier, was it still relevant to the fall? We're in a different situation now with many high transmission areas. So we went back, and in about late November, we wrote this story where we tried to ask some different questions that schools all over were grappling with. So this is a sample of our stories. And I would say that this experience for me, there are two things that have really struck me in covering this topic. One is the degree, the emotion and the passion that people feel on both sides of this issue. And there was an infectious disease doctor in Canada who made a point to me that she said people interpret the data one way or another to justify one end or the other. And that is something that I think my colleague Gretchen and I have both experienced in our reporting. People can be looking at the same data and they can present a different interpretation of it. So that has been challenging. A second issue that has really been striking is how quickly the environment is changing in which we are reporting and living. So our last big piece that I'm showing you here was 2 months ago, which doesn't feel like very long ago, but we're now in a different chapter in many countries with more transmissible variants. So the question is, does this earlier reporting and the research really on which it was based still hold up? So that's a really big question. So, I think, what have we learned over this year that we can apply right now, and what don't we know? I would say, what do we know? We know that kids can catch and transmit this virus. Now, I do think one thing that has changed over the summer, there was real unanimity that younger children under the age of 10, were less likely to catch and possibly less likely to transmit the virus. And some people still really firmly believe that. Many others don't. Many others think that there's new data that's come out, and it's a much more muddled picture now. We don't know necessarily whether younger kids are less likely to catch and transmit, and hopefully we'll learn more about that, but it's, I would say, more up in the air than it was. However, we do know that schools that have a lot of mitigation measures in place, masks, distancing, small cohorts, ventilation, hand washing, can run pretty safely, and they've, by and large, as many other panelists have said, have managed to avoid detectable outbreaks. So that's very good news. Now, what don't we know? we don't know what the effect of these highly transmissible variants is. We know that the virus still transmits in the same way. So that would suggest that having really good mitigation can still, make a big difference. But we just don't know, will it be enough? And we also don't know what enough is, and what a community defines as, quote unquote, sufficient or safe enough, I think really varies. And we have seen outbreaks in elementary schools in Europe of the new variant. In the Netherlands, there was a case in one school, or a case linked to a school, that led to mass testing of that school. And out of 818 people tested, there were 123 cases. There were not masks being used in that school, but that's a lot of cases in one school. So we really desperately need more information on how these transmissible variants spread in schools. And that's something we'd love to see. And I think there's obviously a lot of variability in how different countries have handled this. Some countries have their schools closed or partially closed right now: Austria, the Netherlands, Germany, the UK, of course. France and Switzerland are open, as we've heard. And then there are differences country by country in terms of the local control of schools. And here in the US, there are suburbs that have schools open, and the urban schools that may be 10-minute drive away are closed, because there's different control over those schools. And I just want to leave you with 2 points that I think are important to keep in mind. So one that's been touched on is what do families want? Now, there's often talk about opening schools to support families of color, families who are in poverty or who are otherwise more vulnerable. And these are often the same families that have been hit harder by COVID. Now, data from the US actually suggests that these families, for many reasons, are more fearful of attending in-person school. And a great example of that is in New York City, which did reopen its public schools as a partial reopening. And there we have seen many more white families who are, trend a little more well off, sending their children to school than Black families. And that's held up in other areas as well. And just the last point to leave you with is that while, many of you probably know that masks have been very politicized here in the US, where I am based, many schools that have opened do have very, very strict masking requirements, as was touched on earlier. And 4- and 5-year-old children are in masks all day long, except when they're eating. And to be honest, I had my own doubts about how that would work, but it's gone very smoothly. And I know children who say that they don't find masking hard at all. They'll get in the car after school and forget to take off their mask. They may find distancing even more difficult than masking. So I think when we're dealing with these very transmissible variants, that may be something to consider, whether it's worth having, very strict masking, even for younger children. And sometimes we underestimate what children are capable of. So thank you again for having me.
Jennifer, thank you so much. And thank you to all the speakers throughout this webinar. I'm going to hand back to Phil.
Thank you very much, Fiona. As predicted, we're slightly running out of time, and we've got hundreds of questions, and we're not going to be able to answer them all. Probably would have been best to spread this out over 2 webinars, but the next one is in 2 weeks' time, talking about the role of asymptomatic testing and rapid testing in controlling spread. So please check in on that. If you struggle to take in all the facts in today's webinar, as I did, it'll be up on the BMJ YouTube website from tomorrow. So you can watch it again. The slides will be made available, and any friends or colleagues or children under 18 who might be interested in cherry picking bits of it, please send that link to them. Nikki has some questions. Nikki, how are you?
I'm good, thank you, Phil. So obviously we've said that it's not been as black and white as having schools open or closed, but one big question that keeps coming up is whether schools should have been closed in this 3rd lockdown.
Should schools have been closed in the 3rd lockdown? Who would like to take that? Is Sunil still there, actually? Sunil would be good to take that, I think, if he's still there.
I am still here. I'm probably going to say something similar to what I said, which is that closing them has caused great harm. And it will be for the infectious disease control people to tell us whether it's caused great benefit. And, that's what we're trying to establish. I don't have anything better than that to say.
If you were trying to make the case, Sunil, at a Downing Street press conference, how would you phrase it? Because that's the issue, isn't it? If somebody says we as adults have to accept a little bit more risk for the sake of our children, I mean, how would you win the argument with the wider public and teachers, given that there's scary new variants that might be more virulent and we've got to adapt the precautionary principle now? How will we ever get schools open when we're moving to being more cautious?
Thank goodness I'm not a politician, Phil. It's a tough sell, tough sell. I don't know, and I don't even really, I don't know. It's about values and it's about prioritization. I think the concept of the social interaction budget, which I think, was discussed last summer a bit in the UK. I haven't heard so much of it talked about recently. We have closed certain areas of society, certain sectors of the economy and not others. We've closed schools, but we haven't closed, just for example, we haven't closed construction. So there are reasons for that. It's not because there's no transmission in construction. It's because we value it. We think it's really important to keep the economy going. So I would say, put all these things out there, discuss them and make your choices.
Can I just say, I think you'd be a tremendous politician and you'd certainly get my vote. So
okay, some of my colleagues might find that an insult, Phil.
Sorry. Nikki, next question.
Yeah, so should we be reopening schools in the UK given Norway's experience and findings in France?
Oh, who wants to answer that one? So should we be open, given what we've heard about Norway and France? What about, is Rachel still here from Scotland?
I am here, Phil, yeah.
So we've heard about the experiences of France and Norway. Do you think it's safe? Do you think, I mean, Nicola Sturgeon is thought of as perhaps a better communicator than some other politicians we have in the United Kingdom. Do you think she could make the case for reopening schools?
Well, I think I'm pleased to say that I think our Scottish Government colleagues have been very clear that they place a very strong emphasis on opening schools. They recognise the harms that lack of education risk to children's well-being and futures. I feel a bit hedgy in the same way as Sunil. I'm not sure it's my decision to tell Nicola Sturgeon what to do, Phil, but it is. I personally and professionally am very keen to see schools open safely. I think it is important. I think low community transmission does help us achieve that. Okay. So I'm pleased to see our case rates coming down, and it will be for the politicians, not for me, to decide when schools reopen.
Thank you. Would you believe it? It's 6 o'clock. We could go on all night, but our slot sadly only takes us up to 6. Thank you for Zoom for giving the BMJ donating this free service. But remember, our next webinar is in 2 weeks. So start registering for that, spread the word, and tell your friends that they can see this webinar on the BMJ YouTube channel. Thank you to just an extraordinary range of speakers. Do you want to say anything at the end, Fiona?
No. Thank you. It's been great. So much to talk about. Keep talking.
Lots of known unknowns to end on. Just write them all down and bring them back to the next webinar.
Thanks.